Good morning. The topic is X-ray chest. Now, you are a GP. I am a consulting physician. I mean, high-class GP. You are more than me because I only know medicine. You are supposed to know surgery, gynec, skin, all the specialties. Anyhow, but X-ray chest or X-rays are seen by doctors who are known as radiologists, imaging specialists. What is their work? They sit on the table. X-rays can come. The X-rays can come from America. They are sitting here and seeing American X-rays and earning money. One of the most lucrative practice in radiology. Lakhs of rupees you can earn if you work hard. And please remember one thing, if you want to become a radiologist, the private hospitals who charge 40-50 lakhs rupees for postgraduate, say like you want to become a physician, alright, 30-40-50 lakhs. But if you want to become a radiologist, highest fees they are charging 2 crores to 5 crores. Now you see, if these people pay so much to get into a medical college, naturally they will earn more. Anyhow, what I am saying is, we are not radiologists. So don't try to show off your knowledge that you are trying to pick up shadows and diagnose. But what I want to tell you is this. Your patient goes to a radiologist, which is like a shop. He is like a customer. The radiologist doesn't even see him, doesn't talk to him, doesn't touch him. The technicians are taking the X-rays, and later on the report is being written down typed by secretary, handed over. So when the patient comes with this report which shows that tuberculosis in the right hand, he doesn't believe. He doesn't believe it. He will come to you as a GP, as your family physician, and he wants to hear from you. Is there a shadow? Is it tuberculosis? Now, I cannot teach you radiology, imaging, but what I want to tell you is this secret. The patient thinks we know imaging. Nothing wrong. Let it be. Good. You know, in my clinic, this is my consulting room. And I tell doctors you should have same thing. Examination room should be separate, consulting room, small corner. It's not a very big, very small space. And then waiting room outside. Now if you note that this is the view box, and see at the moment 3 patients' X-rays are being put there. One is some CT scan, one some X-ray chest, and then somebody else with some X-ray bone or something. Before I go further, I want to tell you, I don't want to impress you, I want to teach you, I want to stress that look at the number of chairs when I am taking this is for history taking. The consulting room is for history taking. Examination room is for examination. And when you take history taking, look at the number of chairs I have got. 1, 2, 3, 4, 5, 6, 7, and there are, I'm sitting here, there are 3 chairs behind me, 10 chairs are there. So if the patient comes with 10 people, welcome, I welcome them. Aaiye, baithiye. That means these patients have got some soft corner for the patient. Must be father, mother, brother, friend, neighbor. Maybe neighbor also has come. And now you start asking history. And they are watching you, how you ask the history. Therefore, I go on telling you, history taking is an art. And the way in which you take, and maybe one of these days, I'll start these lectures on 2, 3 lectures on history taking. So you ask the patient, what is his complaint? Now, look at this view box. I want to show you this view box which I have got is 6 feet by 4 feet. 6 feet by 4 feet. Even the radiologists don't keep in their rooms. Why they don't keep? Because they have got a separate system, they have got so many secretaries and all that. But I am a physician, I am like a GP. I must have this much big view box. Why? Why? Because I want to save my time. Time is important. There are 20 patients sitting outside and I have to finish them in 3 hours. What do you want me to do? How do you save time? This will save time. One secretary or your assistant comes and puts the CT scan of some patient. 1, 2, 3, 4, 5 pictures. Second patient, third patient. Now, patient wants me to see the shadow and diagnose. Okay, I'll also pretend. I'll also, see, I sit here and this is the view box, patients are sitting there. Now see this switch I've got a switch to switch on the view box. So when I finish taking the history, I take the patient inside for examination. And then I come and still I want to go to the view box, I press that button and the light is on. So patient is also surprised that I'm going to see and the light is on. These are the small secrets where the patient has faith in you, that he has got some. And then of course, before going there, I will see his report here, what he has written on. He is a specialist regarding the tuberculosis of the right upper lobe. Right upper lobe. So when I go there, I take this pointer with me and I go to the right and I start looking here, yes, there is a shadow. So I will tell the patient, yes, tumko tuberculosis hai. Then only he will believe it. Because I have taken the history. Then I took him inside to examine him. 20-year-old boy. He's got cough, fever, he lost 5 kilo weight. 20-year-old boy. Inside when I tell him, remove all the clothes. He removes all the clothes. And then while removing I see a matchbox. Matchbox? How many do you smoke? He can't be having matchbox for nothing. He must be a smoker. So you tell, how many do you smoke? Tell me the truth. He said, 10 cigarettes per day. Stop it. Stop it. Last week only my patient who was a smoker, he got cancer of the lung and died. Last month my smoker patient had a heart attack. You want to get all these things? You are 20 years old. Stop it. Then when you are examining him, when you are coming to the genitals, you see a small hydrocele. And then he looks at you, says, doctor, this is going to affect my sex. No, nothing. This is for show. In men, these two testicles there are for show. So if it has got a little water, nothing. If you want, don't treat, don't do any operation, forget it. But about your sex, do you masturbate? Yes, I masturbate about 2 times a week. Very good, very good. That is what you should do. Till you get married, don't go to a woman and you'll get AIDS and then you'll have problem. And then you examine him top to bottom. So now you see, as I told you, you are a GP. You are not supposed to treat tuberculosis only. It's a physical illness for which the patient has come to you. What about his mental health? You solved it inside already. What about his social health? How many brothers, sisters there are? Later on I'll talk to you about this. So you're supposed to treat him as a whole. He is your patient, you are his doctor, you are his guide, you are his God. That is how the faith develops. No? What is faith? What is faith? These are the small things which you will do in private practice and win the faith of the patient. Here is a X-ray of a patient. I had asked for, this patient had come for pain in the left lower chest when he used to breathe and coughing, and while he coughed the pain was there, he had fever. So fever, cough and pain. My diagnosis was either he has got a patch of pneumonia there or pleurisy. There are only two conditions. It can't be. So I asked for an X-ray chest and see what the radiologist does not even talk to the patient, does not even ask him what is your complaint. In olden days when I was a student, my radiologist teacher there, if you send a patient for an X-ray chest without writing what are his complaints, he'll throw away the whole thing. He just said, get out. What do you think I am? He'll say. So he would like to know the history before taking an X-ray. So if the patient says he's got a pain there, so he also knows either pneumonia or pleurisy. Now these people have not asked history. Now look what he has done. Now even the left corresponding angle is not there. The X-ray is done in such a way, this is cut off. This is cut off. Diaphragm is not seen. Then what is the sense of this X-ray to me? What did I achieve? But only thing was it was cheap, 300 rupees. Now I'll ask for sonography. Why should I repeat the X-ray? Because sonography costly, 2,000-3,000 rupees. This is 300 rupees. But I'll come to know is it pleurisy or not. I kept this X-ray to show you that the X-ray chest is very easy. I teach it in one lecture only. It was 7 hours, 6 hours. That's not the point. The point is, X-ray chest is very easy because this photograph which you are seeing, it shows black and white. Black and white. That's all. There is nothing else in this X-ray. In this photo, what are you seeing? You are only seeing black and white. And the black which you are seeing is the air in the lung. Air in the lung, air in the lung. It's all black. Then the question comes, if air is black, this should be all black, which is black, but then white shadows are there. So now what are the white shadows? That you should know, so that you don't get confused. Because ultimately it is a white shadow which will be there, which you are going to interpret, for which you have taken the X-ray. So white shadow, even this, for example, see this, white. This is the scapula. Scapula is seen here. So this is not a shadow in the lung. So you say, oh, this is not a shadow in the lung. These are ribs. So I tell you, if God had made the ribs like this, I could have taught X-ray chest in 20 minutes. 20 minutes. Because it will be very easy to show me all the shadows. Unfortunately, the ribs are like this. You see, they start from here, spine, and they go like this. Not like this. Not straight. Now, when they go like that, that's a problem. Here it is so high, and here it is so low. That is then crisscrossing. That is why all this dirty, which confuses and frightens you about are you missing any X-ray, any shadow. So anyhow, so the point is this, in this X-ray I can show you something. This X-ray is not very good X-ray, first of all. Why not good X-ray? He missed out the corresponding angle, number one. Number two, this X-ray is not very good because the heart, you look at the heart, it should be more white. Where is the white? Where is the white here? That means something wrong in taking the X-ray. And the center is too much white. Too much white. Too much white, so much so. And not only that, I can see the intervertebral discs. This is the vertebral column. I can see the intervertebral discs here. See? Discs here. I have not taken the X-ray to see the spine. I have taken the X-ray to see the lungs. This is wrong because it's so much white. So you can see the air in the trachea. Beautiful. Why? Because too much white and then black. Anyhow, X-ray is not taken. Well, I mean, radiologist has not given any time. All these technicians must be useless. But I want to show you the white shadows. These are the clavicles. This is the spine. It is white. And the aorta will be white. So aorta starts like this. See here. And this is aorta. So aorta goes like this. It starts from here, then it goes on into the abdomen. So all this is aorta. White. Then pulmonary artery. See, there are two big vessels in the chest. Please remember that. In the past also I told you. You are looking for a heart disease. Patients got dyspnea on exertion, and lung is normal. Heart echocardiography normal. No, you are missing pulmonary artery. The pressure, pulmonary hypertension is a disease which produces symptoms. So please remember, aorta is one vessel. Yes, it's the biggest. There is no doubt about that. I'm not saying that. It goes right down into the abdomen. But next to that is the biggest pulmonary artery. So pulmonary artery comes to the lungs to supply blood, which is to be oxygenated by the lungs. So now you see how the main pulmonary artery you can't see. Why? Because it is hidden here. Hidden. It's small. But it branches into left and right. That I can see. This is the left branch of the pulmonary artery. This white is the right branch of the pulmonary artery. So it will be smaller than the big main, which I can't see main. Now see, when these arteries enter the white shadows, now see how they branch. Now this has to supply the blood to every part of the lung so that the oxygenation takes place. Now you see how it does it. Now you see how it branches here, branches there, branches. You see this, branches here, branches here, branches here. It goes on branching, small branches. This you should remember that. So these are the white shadows, remember that. But they are very fine white shadows. There is no question of that. So that means this is not completely black. Which means lung is not completely black. Because these vessels, when they go here, they are producing this white small shadows. So this you should know. And this is important. You know, the commonest diagnosis which the radiologists give is such nonsense, I tell you. Bronchovascular markings prominent. They don't know bronchi. Now here is a trachea, air. Now in this particular X-ray I can see the air here also. Is the right bronchus. The bronchi will show air. The vessels are white. So we call them bronchovascular marking. But there is no meaning of that word. The meaning should be, which I am going to show you later on, that is this fibrosis? Is this fibrosis? Is this fibrosis? Is this fibrosis? Tuberculosis. I say no. Why? Because this is coming from here. I can see it branching. So when you see branching, you are happy. These are the normal vessels of the lung. So this X-ray at least shows you, and here of course you can see the apex beautifully. The apex is so often not seen clearly. And unfortunately, tuberculosis is common in the apex. And if I can see this clearly, I am sure it is black, no tuberculosis. And then the ribs, when they come, they start higher up and they go down like this. So the first rib will come like this. second rib. I'll show you further in another those X-rays. Now, first of all, I want to stress that patient comes with chronic cough. The commonest disease in private practice we see is chest allergy. Commonest, much more than tuberculosis, much more. Much more than tuberculosis. Commonest chest allergy, and the X-ray is always normal. Now imagine a commonest disease you are seeing and you can't confirm. There is no shadow in the X-ray chest. That is a tragedy. That is a tragedy. COPD. Smokers get this disease. X-ray remains normal till the end. The patient who can die with normal chest X-ray. Bronchiectasis is a disease where bronchi are dilated in some portion of the lung and they bring out cough and sputum, cough and sputum. X-ray is normal. ILD, interstitial lung disease. This, in the end, I am going to talk about 1 or 2 minutes on this because we are seeing more and more patients and they say it's becoming more common. It's not becoming more common. It was there. We used to miss it. We used to miss it because X-ray looked normal. You want to diagnose. Many doctors have got that complex, and fear. Oh, ILD. If I miss, you can't miss ILD. You don't need to see an X-ray. If any patient 30, 40 years old or any complains of dry cough, and when he walks, he starts panting. Dyspnea on exertion, not on sitting. Bronchial asthma patient the whole night, they go on. This patient not like that. He says he can't climb steps, he can't walk day by day. And the third symptom is he is losing weight. He has lost 5 kilo weight, 10 kilo weight. But losing weight means tuberculosis. And you think of but he has no fever. He has no sputum. What will you send for examination? Moment you get these 3 symptoms, please tell your secretary to put the pulse oximeter, see the oxygen. If oxygen is even little less than 97, 96, you are possibly correct. But now you do 6 minutes walk test. Tell your secretary, walk with the patient, normal walk, 6 minutes. If the oxygen falls down by 5%, you have confirmed your diagnosis of interstitial lung ILD. You don't need an X-ray, you don't need any investigation. I can challenge you, you will be correct. You can't go wrong. And then of course, CT scan will show you ILD, X-ray cannot show. Then chronic cough can be due to outside the lung disease like GERD, acidity. So many patients can have, but now the doctors who want to learn and all specialists, they go on giving antacids and omeprazole in all cough patients, chronic cough. No, how will you? They have got also side effects. Please don't think that any allopathic drug has got no side effects. All these omeprazole and all which you give, do you know they can increase your fractures of the legs you can get without osteoporosis? Do you know they are the next nephrotoxic drugs next to your NSAID? All the painkillers which you take, strong painkillers, they cause kidney disease, kidney damage. The next one is this. So I see patients taking it for years. Wrong, absolutely wrong. I will diagnose cough due to this in an old man who is lying down with a thin pillow and he is not well, nothing, and he is coughing. Most likely because by the time you are old, the hiatus becomes loose. You already have nearly hiatus hernia. So this man I will diagnose. Then I will tell him to raise the head end of the bed, that's all, but 10 inches. Omeprazole for 2-3 months. The most common thing missed by the GPs, and it's a tragedy I tell you, is this post-nasal drip. When I took the lecture on tools for the GPs, 100 tools for GPs, I stressed this point so much. That cough is a very common complaint and chronic cough. Unless you press the tongue properly and see behind the palate, if you see something hanging, thuk is hanging, that is post-nasal drip. That is the cause of chronic cough, and that will only respond to an inhaler. You just put one of these drip in the nose spray. You put this spray there, put the spray there, in a few days the cough becomes alright. Then if you talk about the cough, tuberculosis, yes, you can have a normal chest X-ray with tuberculosis. It may not be seen at all, because now you see there are so many conditions. The shadow could be in the apex, tuberculosis, you can't see it. The shadow may be behind the rib, you can't see. Exposure of the film, like I showed you. Similarly, some miliary tuberculosis, which is very fine. And then you think tuberculosis in the chest is in the lungs. In the chest, when you are seeing the X-ray, what about the hilum lymph nodes? What is the lymph nodes? Lymph nodes are small glands which are present all over the body, and the tuberculosis is extremely common. And next is lymphoma, cancer. Cancer of the lymph node is one of the commonest cancer. So when you examine any patient, please, and they can be silent cancer, so please examine the lymph nodes in the neck, which is very easy to do. Not this, these are tonsillar behind. You can examine the axillary axilla lymph nodes. Prithviraj Kapoor, the first patient of mine in the film industry, I diagnosed Hodgkin disease by feeling a gland a size of a walnut in the left. He was such a fat man. I saw that and I saw fever running for 2 months, spot diagnosis. I said, this is Hodgkin disease. So easy to feel. You don't need, and you will miss it on X-ray. Very difficult to image it. So even the chest glands, you can't. Abdomen gland, you can't, unless you do sonography. But in the groin, you can diagnose. So groin should be seen properly. The tuberculosis may be. So what about these chest glands? These chest glands called as mediastinal gland. So lymph nodes in the chest can have tuberculosis. In UK, the commonest disease is sarcoidosis. We don't see sarcoidosis; they're very rare. So you are searching for tuberculosis, and the lungs are absolutely clear. There is nothing like this. What I told you. Suspect mediastinal glands, mediastinal lymph nodes. Look there. They may be having tuberculosis, and unfortunately, mediastinal glands are in the hilum, where there is pulmonary branches, pulmonary artery, which I showed you just now. So how will you differentiate a shadow like this of a artery and a gland? You cannot. Both are in the hilum. So then you will have to have CT scan. But how will you suspect mediastinal gland? The patient has got fever, cough, but there is no sputum. There is no sputum, otherwise everything else is in favor of tuberculosis. Think of this. And if by chance you can feel a gland here, then your diagnosis is already over. He has got lymph node tuberculosis there, and he has got here. Finished. Early pleural effusion. Early. You can miss it easily in the X-ray chest. So today for pleura, the imaging is sonography, not X-ray. Sorry. Similarly, reactivation of tuberculosis in old cocks. It's not common, it is very rare. And to prove that, you might need lot of investigations. Similarly, a small cavity can be missed, which we'll see. So, important thing is symptoms of patient, cough. You are looking for cough which has got, where the patient is fever, patient is losing weight, has no appetite, or he has passed a blood clot. So, patient passed a blood clot. Patient passed blood in the sputum is not the correct language. Blood in the sputum, commonest cause is gums. I have shown you earlier in my lectures. The patient says he passed blood, bright red blood, and he gets frightened. Usually it is in the morning from the gums. And if you massage all the gums, you will find one of the gums, blood coming out from there. Show it to the patient with a mirror, with all your tools. Tell him blood is from there. But if he has brought a blood clot, the clot has to come from here. So if that is so, then X-ray test will not help. Then you have to have a CT scan, because the commonest diagnosis is bronchiectasis. Types of pulmonary tuberculosis. I mean, you talk of TB, but you should know something more about TB. What is more about TB? That tuberculosis can be active tuberculosis, latent tuberculosis, old tuberculosis reactivation, hilar gland tuberculosis, pleural tuberculosis. Forget about the heart. I am not still discussing. Heart is also on the X-ray chest. In the heart, pericardium, so common, tuberculous pericarditis. Tuberculosis of the pericardium of the heart. But we forget about it. Similarly, lung tuberculosis, if it is MDR, multi-drug resistant, you are not supposed to touch this patient. Don't treat this patient. He is going to die. He can be saved only by a chest specialist, because they need multiple drugs, and the drugs which will cost you maybe 10,000 per month, where those patients help you to get the drugs, the specialists and all that. Similarly, miliary tuberculosis is one where there is a small spot, but it affects the brain and you die, 100% death. So it should be diagnosed early. Similarly, in every lung patient, TB patient, HIV has to be done. Blood sugar and HIV, these two tests if you don't do, wrong, absolutely wrong. I have brought patients in my lectures on the stage in Birla Hall, 1,500 people are witnessing it. Young girl means 26-year-old, diagnosed as tuberculosis. Of course, very good, soft shadows and all symptoms of tuberculosis. And she is getting all the good drugs of tuberculosis. She is not responding. She comes to my clinic. In my clinic, though, as I said, every patient urine must be examined. Albumin, sugar, that's all. Even if you don't do microscopy, albumin means she has got a kidney disease. Sugar means she has got diabetes. Simple. Nothing. Here sugar was not done at all. In our clinic, though, we found out she was a severe diabetic, therefore she was not responding. So what we are discussing today, what you are talking about, active tuberculosis, where patients have got symptoms of cough, of fever, loss of weight. But if patient has got no symptoms at all and yet she has got tuberculosis, what will you label it as? Latent tuberculosis. What is latent tuberculosis? All of you have got that. I have also got. Everybody in India has got latent tuberculosis, which you can't see on X-ray chest. Rarely you might see some spot and all that. We don't treat it, we have no symptoms. But it is said that any of this latent tuberculosis can flare up if your immunity goes down. You start drinking whiskey, half bottle every day. You start smoking 20, 40 cigarettes per day. You start taking so much gutka every day. Your immunity goes down. Then tuberculosis can appear. So that means it has got some meaning. It hasn't got no meaning. And if you have got all latent tuberculosis, you don't need any treatment. But very sorry, you can't get a job in America, they will not take you. You can't get a job in Dubai. All these people who are very intelligent, who can earn a lot of money here, but if they go to Dubai or America, they can earn double. These people who have got latent tuberculosis cannot. They are not allowed to enter. So when you go to America, you have to prove that you have no latent tuberculosis. That's all. That is the only value of this word, latent tuberculosis. Old tuberculosis. Oh, if you got a old tuberculosis shadow in the lung, very sorry, you can't go to America and Dubai, etc. You people then you should go and do business there. Don't look for a job. Hilar I was telling you just now, easily missed, and CT scan can pick up pleural tuberculosis, easily missed, unless you start doing sonography. So this GPs, I see, especially in Bombay though is famous for, the pathologists are minting money. All the GPs are sending the blood for TB IgM, TB IgG, TB IgA, TB IgG, blood TB, PCR, TMA, AD, all these tests are 100% useless, 100% except this. But this test is not done for diagnosis of tuberculosis. It is done for diagnosis of latent tuberculosis. That means even if you are going to America or whatever, you get this test done, not otherwise. A normal person with a shadow or something, we don't get TB gold interferon done. So latent tuberculosis is a business topic. Somebody, your son, you are the guide in the whole family, so somebody is going, so you have to tell them, first do your gold interferon test or Montux. We do Montux test. Montux is a very good test to exclude. All of us are Montux positive. That is because we have got latent tuberculosis. So if Montux is positive or blood test TB gold interferon, it's a costly test, but you have to know 2 visits are required. Montux you have to go again to show. So otherwise, this is for it's for business. We come to shadows. Black and white. What is a shadow? White. White is a shadow. So you look for white. When you look for white in a black background, now here is a black background. I have drawn the chest like that. Now here, if suppose I am looking for a shadow, and suppose I see like this. There is a shadow there. Finished. You have diagnosed disease. It's so easy, because it's white against black. White against black. But as a good GP, what you should know is that there are 2 types of shadows. One which your child can also see. Anybody is, arey kya, arey. But there are other shadows which are called as soft shadows. Now see, if I want to make this as a soft shadow, see what I am doing. In my X-ray class, I must have a big blackboard. In my X-ray class, I should have a screen, 20 feet long screen, where 1,500 people can see such big shadows from the last row. That is because of imaging, which is available for teaching purposes. So I am now showing you that if I do like this, now this shadow becomes soft shadow. This becomes a soft shadow. I can do it more soft, more soft. More soft, more soft. Why? Here, this is a hard shadow. Pneumonia, fluid, this tuberculosis also. And later on, which I will show you again, that if I do like this, this is calcium. Calcium. This is calcium. This will never go. Once you got calcium in your lungs here in the shadow. So some patients, when they heal, in olden days it was very common, the tuberculosis is healed and they are left with that sillish calcium shadow. These shadows remain permanently. Somebody is getting married and somebody saw the X-ray. अरे वो लड़के को तो टीबी का दाग है, आप शादी कैसे कर रहे हैं? That poor fellow is labeled as TB lifetime. Nothing is normal. He can get married, he can produce children, he can do anything he can do. No problem, but that's a scar, like he has got a scar here, he has got a scar somewhere else, there is a scar here. And you can't go to America, you can't go to Dubai, you can't go. This is the disadvantage of this calcium shadow. So you should know what are these shadows, and to see soft shadow, you should have what? Good view box. Do you know how much diagnosis I must have made from my view box, which I bought how many years back? 40, 50 years back. I spent how much? 40,000 rupees. Those days. I got it made. I recovered all that money, much more than that. You people, GPs, have no view box also. Like that they will see. Like that they will see against this light, against this light. You should have a view box. Then I see many GPs, they've got a view box. Yes, sir, I've got a view box. Yes, my uncle, who died, took his clinic. He had bought it. But I can't see any light in that. If you can't see any light in that, then what is the sense of the view box? View box has inside a tube light. It must be changed, no? What I want to tell you is that a very good view box, and as big as possible, which you can, depending on your practice, depending on how much practice you have got. Very important for X-ray chest. Similarly, many patients, they change the doctors. Somebody diagnosed tuberculosis. He started treating. After 10-15 days, he becomes restless. I think it may not be TB. Now he goes to second doctor. Doctor, I was diagnosed TB. You think this TB? By the time that shadow becomes hard, that soft shadow has become hard after treatment. He will think that it is increased. It is not increasing. This is the change in the shadow during the treatment. If you want to know that is he responding, you ask him symptom. Is fever gone? Are you getting some appetite? Are you eating food well? Have you put on 1 kilo weight in 2 weeks? Cough is less. That is called follow-up. Not photo nikalo, फिर photo nikalo. No. And if pulmonary tuberculosis is missed, that is because you are calling it pulmonary tuberculosis. The higher lymph node tuberculosis, pleural tuberculosis, you are not using the word. And if you are missing it, if you are doing still the old test of acid-fast stain to see acid-fast bacilli, Zale-Nelson stain, formerly we used to tell, thug nikalo or ye test like nikal ke aao. And please do look for AFB with acid-fast stain, Zale-Nelson stain. If it is positive, he has got tuberculosis. If it is negative, he hasn't got tuberculosis. Wrong, absolutely wrong. These are the days when, you have got mobile and you are keeping a landline. Of course, I do it in my house because I don't want to take mobile. That is not the point. Point is, if you want to be in circulation, you have to have mobile, latest, not landline. So similarly, these patients, when they come for tuberculosis, the sputum should be sent not for the Zale-Nelson test, the latest test which has come. And in that test which we are doing now, 130 for the sputum test to be positive in the microscope with the Zale-Nelson stain, there should be 5,000 to 10,000 germs. The patient has brought out thuk. The thuk is being examined, Zale-Nelson stain. There should be 5,000 to 10,000 germs for it to be positive. Otherwise not. Less than that it won't show you. While our latest test which we have now got, 130 germs in the sputum can be caught. What are you comparing? Where are you? You have to change for the pathological diagnosis of the sputum, whatever you are sending for examination. So the lung shadows are, here is a patient, she had pain in the left lower chest again. Now, mind you, when I say white shadows, the trouble in an X-ray chest, white shadow is a female patient. You are stuck up. Because they have got breasts. Breasts cause the white shadow. Breast is not going to show black shadow. In a very young lady, younger the lady, younger the female, bigger the breast, more beautiful breast, more shadow. Why I am saying young? Because see, this is the first rib which is coming here from behind. I can't see from here. It must be coming from there. Spine. It's coming like that and coming here. Parallel to that is the second rib. Now all these ribs come here and stop here. Stop. This stops here. Why doesn't it continue up to here? Sternum is here. It is attached to the sternum. Sternum again is not a bone, so it doesn't cast a shadow. So this stops here. This I am going to show you number of times today. That stops here because this is cartilage. This is not bone. Bone is up to here. This is cartilage. Bone up to here. Cartilage. 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 What you got in the nose? Cartilage. Cartilage does not throw shadow. Does not throw shadow. But if this cartilage gets calcified, this calcium in that, then it will throw a shadow. And that happens as you grow old. As you grow old, you will find calcium, 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 calcium here. And this calcium here, oh, so many people, TB, TB, they say this TB. This is not TB. This is normal. You see on the other side also you will see that this costal cartilage is calcified. Calcified. Anyhow, this lady with big breasts and all that, and the costophrenic angle, see that angle is this angle, which is very beautiful, and obliterated. So, pleural shadow. Now, I cannot tell you is it thickened pleura of some old pleurisy 10 years back, 20 years back, or is it fluid? Here comes the value of sonography. Sonography in 1 second it will tell you there is 200 ml of fluid there. And under sonography, aspirate, aspirate, send it for examination. Unfortunately, the examination of the pleural fluid, ADA, adenosine deaminase, is not a very good test. So we haven't got still a very good test to diagnose tuberculosis of the pleura. So all the pleurisy in the effusion which we treat as tuberculosis, not 100% sure. Tuberculosis can be so much. I had a patient who I was treating, I was sure, young girl, middle class family, pleural effusion, tuberculosis I was treating. After 2-3 weeks they came, बुखार नहीं जाता है. She is still having fever. She is still having fever. इतना बाल गिरता है बोलता है. When she takes bath, so much hair comes out. So much hair comes out. I've never heard of this side effect of tuberculosis drugs. So I saw that, and I again saw her whole skin. I said, "Koi chamdi mein?" They showed some patch, skin lesion, loss of hair, fever, pleural effusion, lupus, systemic lupus, SLE. I said, "I'm sorry, my diagnosis was wrong. This is not tuberculosis. This is lupus." But again, lupus is a very rare disease. You don't think of it as a GP, I'm telling you. But if you ever have got fear in your mind, is it lupus, lupus? I said, one blood test, ANA, finish, anti-nuclear antibodies. If that test is negative, no lupus. Very easy, no problem at all. This is called soft shadow. So it's an ill-defined shadow. Soft shadow means it's ill-defined. It's not, see here, very. And again, very young patient. See, first rib coming here, stopping here. Second rib coming here. Young patient having active tuberculosis, but this is a hard shadow. The hard shadow, very white, very white. So, hard shadow, soft shadow. So, soft shadow can be missed. This can't be missed. In fact, you will call it pneumonia. Okay, pneumonia. homogeneous pneumonia. But pneumonia in our country, in the upper lobe, 90% tuberculosis pneumonia. Take it from me. In our country, you get a pneumonia of the upper lobe. But this is called the hard shadow. That is soft. So soft shadows don't miss. This patient has passed a blood clot. X-ray chest normal, has nothing to do with that. Has to do HRCT scan. Why? Because the commonest thing which you will find is bronchiectasis. Either from birth or after tuberculosis, some patient develop bronchiectasis, which is not seen on X-ray chest. Good. They can go to America, they can go to Dubai. But if you do HRCT scan, you will pick up bronchiectasis, for which again there is no permanent treatment. Surgery could be done if you want a small patch, but this patient of mine, about 7-8 years back, came. That time my fee was 20,000 rupees, and I'm middle class patient. I have only middle class patient because we do all the other tests. No, we do all investigations, X-rays, the cardiac, and the blood tests, urine, this, everything outside, and even they brought this boy, about 18 years old, and I found mother with that, father, uncle, then his elder brother, then his neighbor, 5 people coming with him. I was wondering, what is this patient? What has he got? And they had brought this photo. This photo, and my secretary put the photo in the new view box. From the view box, from a distance, I could see there's a huge shadow, white shadow. Anyhow, I asked this patient, what is your problem? He said, chakkar aata hai. Kamzori, भूख नहीं लगता है, दिल नहीं करता खाने का, रात को नींद अच्छा नहीं आता है, काम करने को दिल नहीं करता, जाने को सुबह काम करने के लिए जाने का दिल नहीं करता है. He was talking all these symptoms, but he didn't mention cough, he didn't mention fever. I was wondering, I said, what the hell is happening? What is he? And so the X-ray showed such a big shadow. Then nowadays they've stopped doing that, some of them do. I saw the name of the patient. This patient was Madan Mohan. When I saw the X-ray name, Fernandez, I said, my God, I said, this is not your X-ray. And I got a radiologist next door. After I finished examining him, I had to convince him. Immediately got another X-ray and showed normal X-ray. So it could be, see, this is shopping. This is not doctory. Radiologist is not a doctor. He is a shopkeeper. You are not a shopkeeper. You have got so much responsibility. Moment. Another patient, young patient like this, had some complaints, and they showed me this X-ray. When I saw the X-ray of this fellow was hardly 20-25 years. The X-ray, first rib, here, see, then calcium started. Calcium, calcified. Look here, calcified. I said, have you brought your grandfather's X-ray, or your X-ray, or it is your X-ray? He was 20 years old. No, hamara hai. No, cannot be yours. Impossible. Immediately we got this X-ray done from our neighbor and all that, and this shadow and all, we had nothing. So you see, if you can pick up this, and or some other ways, some patient like this will be diagnosed tuberculosis. That's now, here, sorry. Here is a shadow in a young patient, most likely pneumonia. I want to see again this not a very good X-ray, too much black. Where are the lung markings? Where are the lung markings? You should evaluate the X-ray as he taken a good X-ray. Is it a good X-ray or a bad X-ray? Fat females with big breasts. Oh, you're bad luck, bad luck. Sorry. Don't interpret if the patient has symptoms. Because in our country, the breasts are so big, which foreign countries you won't find it. These are the women who deliver children every year. And these are the women who breastfeed them for more than 1 year. They believe, and which is good, supposed to be very good. Breastfeeding is very good for children. So they do good thing, I'm not saying. But every year one pregnancy, every year one. So how many children? 8 children, 9 children. Hindu, Muslim both. Lalu person, same, 9 children I think. So that's not the point. Point is these women, then they breastfeed, they love the children so much. So the breasts become so big and they go on sagging. So the breasts are coming up to here, such big breasts. X-ray chest, no good, sorry. Yes, you can use this, I call it photo, no? This photo can be used in patients with Titt's disease. Titt's disease is, I talked to you in the past, very common in chest pain. This patient comes, doctor, बहुत दुखता है, इधर बहुत 1 महीना हो गया, 2 महीना हो गया, और किसी ने फोटो नहीं निकाला. अभी हमको क्या मालूम अंदर क्या, आप डॉक्टर प्लीज फोटो निकालो. They want photo. And even if they don't say, you ask for a photo to show them that see, it's normal, and show them that area which is costal cartilage where there is no bone, and show them why is it black. It's cartilage. So cartilage is like nose. So you're having chronic cold of there. This is chronic cold here. Then, moment you diagnose tuberculosis, you are not a general practitioner. You are their well-wisher. You are their guide. You are their God. Please get the X-ray chest of all the family members and all the servants in the house. This is the first thing you should do. No, nobody does it. Bad, very bad. You know how you develop faith. These are the things which bring faith. Because when I do like that, then I find it's a big family. There is a grandmother also, grandfather also. They are also alive and they are big. But grandmother is very old and coughing. They say they do old age and all. And I find out all the X-rays, grandmother has got tuberculosis. Missed. She has given the tuberculosis to this girl who has come to me for tuberculosis. Or I find one servant. One servant has got tuberculosis. So she has, the patient has not given to servant. Servant has given to the patient. They should be all treated. These are the things which the family doctor will appreciate. And for all extrapulmonary tuberculosis, pleural sonography. I've told you earlier, very important sonography. And this ill-defined shadow and well-defined shadow, cardiomegaly. If any patient with cardiomegaly, enlarged heart, any shadow, ill-defined, attribute it to heart. Don't think of lung disease, you will be right. Similarly, bilateral. Some diseases in the lung are bilateral. Interstitial lung disease is always bilateral, and at the basis, ring shadow is called a ring shadow. This is a cavity. What is the importance? Number one, it can be missed. If you say, oh, very good X-ray, but you have not seen that properly. And these are the patients whose sputum is full of acid-fast bacilli. They are the ones who will throw 5,000, 10,000 germs in one sputum. Always mask. Now people have learned what is mask. They should wear a mask till the cavity disappears. They are the very, very infectious to the rest of the family. Here is a shadow in the hilum. So, I am telling you the difficulty. Why can't it be artery? Left pulmonary artery and all branches. Right pulmonary artery, branches. But how do you know there is no lymph node here? which will throw the same shadow. Dangerous. Always CT scan. It could be tuberculosis, but CT scan, the trouble about scan is this. You do a CT scan and you can see the hilar gland. Alright? So then you say this is tuberculosis, hilar gland tuberculosis. Why tuberculosis? Why not lymphoma, cancer of young people? You have no proof. Unless you do CT guided biopsy with gene expert test, which is a modern test for tuberculosis, not acid for the Zil nasal strain. Then only it is tuberculosis. But my patients are middle class patients. To get this test, you need another 15,000 rupees. So if the patient, or I will palpate again, if he has got a lymph node here, finish, it's tuberculosis. So I can see they're poor, I'll take a chance. I'll tell them, I'll treat you as tuberculosis. You will improve. If by 3 to 4 weeks you don't improve, if you don't, then you need this test to exclude a lymphoma, which is cancer. 3-4 weeks, nothing will happen to lymphoma. It cannot become very bad. So fibrosis, you should diagnose, and all your chronic asthma patients, elderly, COPD, who have got dyspnea on exertion, you should know, have they got any fibrosis? All badly treated asthma patient can develop fibrosis. In fibrosis, you get a lung shadow like this. One straight line. Now, here is a straight line, but see what is happening here, which I showed in the first slide today. You see that branching? See the branching? See the branching? This is not fibrosis. This is fibrosis. No branching at all. What is the importance? Importance is, if your asthma patient has got this, or COPD has got, his dyspnea on exertion will never become normal. He will always need inhalers. Always. Lifetime. That is the importance. Small cavity can be missed because a small hole, and here is a small another cavity like that. It can be missed easily. The radiologist diagnosed ILD in this patient. This patient had, of course, see, look at the lung, the vessel marking. These are not fibrosis. These are not straight lines. These are all branching, branching, branching. How can you call them fibrosis? And ILD is never in this area. ILD is at the bases. ILD shadows are pleural, subpleural, bilateral, subpleural. ILD lungs are small, not big like this, contracted. So ILD, therefore, best thing is to diagnose ILD on CT scan. Here you will go wrong. This is, of course, this is grossly wrong. Because to think, I have already diagnosed it clinically, I diagnosed it by symptoms and oxygen. I only wanted a confirmation. X-ray did not confirm, so we went for CT scan. So what is the next shadow? Suppose X-ray cannot help you. You do HRCT, which now in Corona, though everybody is doing HRCT. But lung are normal, they don't. And HRCT shows so much shadows, so much shadows. When the lung is X-ray is normal. Next is PET scan or even PET CT combined. Best for cancer, lung. You cannot miss it. You cannot miss it. And then you also got a nuclear scan. Please remember that. In nuclear studies, there are some areas sometimes you get caught. Is it cold old tuberculosis or not? Is it so old tuberculosis will be cold on nuclear scan. Active tuberculosis will be hot. So these are the other things. In children, has got you diagnose bronchopneumonia. Then the mother will say, photo nigalo, photo nigalo. What photo nigalo? The X-ray test will not show bronchopneumonia in the first 1 or 2 days when you can diagnose by crepitations. The shadows come late. By the time the child might die. Then you patient of pneumonia, you diagnose. But he is not responding. Today pneumonia must respond in less than 1 week. Must. If it doesn't respond in 2 weeks, then you're missing something. What is that? For example, this is pneumonia, large pneumonia. Why not fluid? Because this is black here. Fluid will start here. Now patient not responding. Do a sonography. There is a fluid. The pneumonia can develop a pus around it. Emphysema we call it. So sonography will diagnose it. Sonography, under that you can tap the fluid, remove the fluid, the patient's fever comes down, finish. So you do sonography to exclude superadded emphysema. Patient like this. Always sonography to be done. In addition, patient of pneumonia, recovered, he is well, but the relations go on telling you, doctor साहब फोटो पे निकालो ना, अभी फोटो में देखो ना ठीक हो गया है नहीं, wrong. The shadow will remain for 1 week, 2 weeks. The pneumonia shadow doesn't disappear completely. So don't get caught. You tell the relations, keep quiet, I'll get the X-ray done after 2 weeks. Today in fever patient, X-rays show small bilateral effusions. Very common, dengue, chikungunya, there are other conditions which are chronic, where these are important, lupus and all that, vasculitis. But anyhow, the point is, every COPD patient has 2 to 3 attacks of exacerbation. This I have told you last time when I have talked about COPD. Every COPD patient. And when he gets his COPD, you have to increase the steroids, you have to increase the antibiotics. But don't forget to take an X-ray. He is COPD for last so many years. But now again take an X-ray. When he is, why? How do you know he has no pneumonia? COPD patients are very prone to pneumonia. That is why we don't have pneumococcal vaccine. But I would say one more thing, as a GP, you are a GP, this man is already 60, 70 years old. How do you know that he hasn't got a heart attack? How do you know? He can get heart attack and difficulty in breathing due to that. How do you know he has no pulmonary embolism? He was in the house, not moving around. Forget about this. This for infection. We don't, in GP, should not use procalcitonin to diagnose infection. So I would say you can always get this blood test done in addition to be sure that this is pneumonia, this is not pulmonary embolism where D dimer will be high in the blood. And anti-pro-BNP, if it is normal, no heart attack. Finish. Then before a few minutes more today I am going to take, because now I want to show there are some good things about X-ray test. You are abusing it, calling it photo, but I want to tell you there is some spot diagnosis on X-ray test. Now one spot diagnosis is, suppose pneumothorax, huge pleural effusion, huge cardiomegaly, any shadow in the lungs with enlarged heart, any single rounded shadow. Now I will show you examples. Now see, the patient of asthma, suppose patient comes with or acute COPD, you think it is exacerbation of COPD, you think it may be pneumonia. For all you know, when you take an X-ray, there may be pneumothorax. And to teach pneumothorax all these years, I used to show this photograph of a burqa lady in burqa. Then I used to show a black and white picture of X-ray, not X-ray. I would take a picture of X-ray and show it. So in the picture the black becomes white, white becomes black, ulta. So then I'll show you, see this is lung, air in the lung, air in the lung, air in the lung. What is this sitting here? Burke wali. What is this? Looks like burke wali. And in the exam they would get 20 marks for the X-ray. If you are wrong, you get 0. So they were very interested in learning X-ray. My X-ray class used to be terrific. For the whole night we used to talk about X-ray class. So pneumothorax means what? All of us may be having a small bubble in the surface of the lung, like a small Same thing like subarachnoid hemorrhage. You got a small thing which doesn't bleed, but one day it bleeds. This one day can rupture. When it ruptures, the air comes out of the lung. Now this air which you are seeing black, which is now white here, is in the pleural cavity, not in the lung. Lung is here. Lung is collapsed. It is pushing the lung towards the hilum and pushes it so that the lung collapses. Now this is your normal X-ray. Black and white. So the black, and you got a very good hint, which I will show you here again, that see, you call this too much air, too much air, too much air, but where are the lung markings? Where are the lung markings? Look at this lung, look at the lung markings, look at the lung markings. I told you in the very first day, slide, you know, it never too black means too much black, but there are some white markings are there. So similarly here now, here too much black, but where are the lung markings? Where are the lung see, look at these lung markings. That means this air is not in the lung, it is outside the lung, and that is pneumothorax. This is a collapsed lung. And here is a picture, black and white picture to show. What? This is the battery is gone. What? Yeah. That black and white picture to show the how collapsed lung can be with a clean margin. Pneumothorax. This patient must be sent immediately to the hospital to put a needle. Once you put a needle here, the whole air comes out. Finish. The lung expands. Very easy treatment. And these calcified shadows which I showed you earlier, bad shadows. Lifetime. There is, it's a very sad. When I see a young man having this shadow, when he gets married, there will be problem. They'll start. When he goes to America, so it's a bad luck to get calcified shadows, which is not nothing, no disease. You had disease 20 years back. That is calcified. Look at this calcified shadow. The lung looks so abnormal. Anybody will say patient hai, shadi mat karo. This is an old shadow which will never go, it will remain, and he has got one very good lung. And if there is a shadow throughout, this is another spot diagnosis of a mega esophagus, because through and through shadow can be only outer here, you can see it cannot outer. Vertebral column, a paravertebral abscess, this vertebral column, you can see up to here, that is out. So esophagus is the only thing which travels throughout, top to bottom. So dilated esophagus, which is due to cardiospasm. Nowadays you are doing endoscopic operation, not. And this, finally this 2-3 shadows which are abnormal, which you should be very careful about. One is this hilar shadow. Hilar shadow, once there is a shadow in the hilum, how do you know it's not a gland? How do you know it's artery? It could be pulmonary artery. See, this pulmonary artery, right branch of pulmonary artery. But the heart is not enlarged very much. So even then, I'm not saying. So what I'm saying is, this could be pulmonary artery, this could be gland, and if it is gland, this should be lymphoma, cancer. Always investigate CT. And shadows in the superior mediastinum. I have treated hundreds in the last 60 years of my practice. I am middle class practice, I have no rich class practice. We are talking about middle class patients. See, she is a female, beautiful breast, young female, no calcification here at all. And poor thing has got fever, cough, and I see a shadow here. There are no glands in the neck, but even then, I say, no, this is tuberculous glands. I diagnose tuberculous gland. But it's not correct. If this was a lady from a high class society, I would never diagnose tuberculosis, never. I say go for investigation. HRCT, biopsy. Biopsy will show that these are not. Of course, there can be other tumors, thyroid, thymus, etc. in the superior mediastinum. And this line, straight line. When you see a straight line in the lung like this is air and fluid. hydropneumothorax, we call it. Hydropneumothorax. Then round shadow. One single round shadow. Single round shadow is a dangerous thing in private practice. Please remember that. Secondary deposit from some cancer somewhere in the body. Check your thyroid. Do like that. Then examine the thyroid. Check the breast. Kidney cancer can be diagnosed. Kidney cancer you will diagnose by urine shows RBCs. Because sonography, chalu sonography said normal. There is a small cancer. You suspect from the urine report. Prostate cancer has no symptoms, but blood PSA. That blood PSA, I must have diagnosed dozens of cancers of prostate. Dozens. See, cancer of prostate has no symptoms. That's the problem. We had this golf man in our club who was a golf champion, who was 65 years old, tall, and he had body ache. Nobody could diagnose what is the cause of body ache. And he came to my clinic. First thing I asked him, have you done a PSA blood test? He had so many tests. The PSA was not done. Secondary deposits in the bones from PSA. His PSA was more than 200. He died. So, cancer, rounded shadows, please exclude cancer somewhere. Here is a rounded shadow in a hilum in a woman, which is the best. But elderly woman, look at this calcium. Very old lady. She was your patient, your center for cancer of the left breast operation 6-7 years back. Now you remember, yes, I had sent you for that. She was all right. Now she comes again for a shadow. Must be again cancer. And finally, 5 minutes I will spend on vasculitis. Vasculitis is just like ILD, is a new disease, again becoming more common because of diagnosis. We are missing it in the past. We used to call Wegener's disease. In the lung there is a shadow, we used to call it. So now, vasculitis, recurrent lung shadows. If you have got shadows which come again and again, and at different places, these are the only conditions which are possible. And I want to stress, as a GP, you can diagnose all this by only blood tests. Don't send it to specialists. No CT scan, no nothing. From the blood test. Why? Pulmonary embolism can come again and again. D-dimer, blood test. Allergic bronchopulmonary aspergillosis. That is rare thing, but it's there in asthma patient. See, these are the now things where chronic asthma patient, you go on calling, you say this is bronchial asthma, now not responding to the treatment, not responding to sir. No, but exclude these two diseases, because this can cause asthma which will not respond to ordinary treatment. You get antibodies in the blood, IgE and antibodies against aspergillus. Then vasculitis, which I was telling you. Vasculitis is a generalized disease. It can affect the lung and cause a shadow like tuberculosis. And just like lupus, I was telling you, there is a test called ANCA, A-N-C-A, ANCA. Beautiful test. I mean, you cannot, it's like in lupus, A-N-A, I told you a GP, if you want to really afraid of lupus, you say, you can talk about A-N-A. Similarly in vasculitis, you want to diagnose vasculitis, just one blood test. Ask for ANCA. Then of course ANCA is MPA, PRO, MPA, etc. That's not the point. You don't have to know that. Allergic vasculitis is a disease which can affect all any organ. Some kidney patient of yours, no diagnosis is made. No diagnosis is made. Did anybody do ANCA? No. If it is positive, that is the cause. Allergic vasculitis. And allergic vasculitis can be treated. That's the beauty. Otherwise they die. Otherwise they die. So lung shadows, and then sinuses. It can affect sinuses. Then here, eye, any organ in the body, joint pains, fever, it's treatable. Like lupus is treatable. Lupus patient live for years together. This patient can be treated with intravenous steroids, 500 to 1000 milligram 500 to 1000 milligram steroids. Cyclophosphamide, which is cancer drug, 500 to 1000 intravenously. So similarly, mycophenolate, and there are all other azathioprine, methotrexate. They respond beautifully, and they can live long. They can live. Formerly they were not. They were dying. Here the patient was treated as pulmonary tuberculosis. I mean, yes, I can understand one specialist. And anybody will say this is pulmonary tuberculosis, so the cavity. But the second specialist who saw was senior. But he also did a mistake. What? He said, no, we'll change the drugs. He didn't ask for the sputum gene expert test. Sputum gene expert test, when I get it, was negative. How can it be negative with a patient with this cavity? So think of second diagnosis. Second diagnosis is vasculitis. This in the past was called as Wegener's syndrome, Wegener's disease. And this patient responded beautifully to intravenous steroid cyclophosphamide, disappeared completely. Then of course he got sinus problem. He was operated there. Then he was there. He was operated. But he is still alright. He is living. So recurrent lung shadows are not tuberculosis. Tuberculosis doesn't occur again and again. Sorry. And finally, two slides of ILD. ILD, you should not know anything except what I told you, clinical. Patient coming with dry cough, dyspnea on exertion, loss of weight, 3 combination, oxygen is less, ILD, finish. All this which I am showing you, these are not X-ray appearances. X-ray may show. They are always at the base, bilateral subpleural thickening and the lower zone. They are bilateral. Lungs are small. The loss of volume, small lungs. What is small lungs? What is small lungs? Opposite of big lungs. What is big lungs? Big lungs is emphysema. You see this in patients, some COPD patients, or some old patients without COPD. They can have emphysema. Means the lungs become big. They actually become big because the ribs and cartilages are expandable. That's why they accommodate. Otherwise they would have broken to accommodate the lungs which became double the size. Here look at the lungs. What a big lung, and black, absolutely black, because there is no vascular markings. There is emphysema. When the diaphragms are pressed down, the best emphysema, if you want to know what it is, you should go to postmortem room. I went to postmortem room for 1 year in my life, and I learned my medicine there. When the boy is cutting the body, he takes a knife and he takes a cut like that, straight there, up to there. What boys are doing? Doctors cannot do all this. When he comes here, when he is cutting here, these lungs come out, these lungs, because they are swollen, and you are cutting. They are so big, so more air. So this is called more air. In the ILD, there is less air. Finally, 5 minutes I think on heart. I'm sorry, today we are going to become 1.5 hours, but now I should finish this topic, X-ray chest. Don't diagnose heart on X-ray, please. X-ray is not for heart. Now, size of the heart. Many patients will say, photo nikal do heart ka, shak hai humko. ECG, I used to teach ECG for so many years. Left axis elevation, and then when the precordial leads, diagnosis of ECG, left ventricular hypertrophy, all wrong. ECG is not for size of the heart. Sorry. For size of the heart, 2D echo. It's only massive. In the last stages, when the X-ray can diagnose this thing. You don't want to wait for those last stages. So no ischemic heart, don't diagnose congenital heart, don't diagnose mitral stenosis. If you want to diagnose, this is left ventricular hypertrophy, very common in hypertension, but enlarged heart, to call it sure, make sure that this is not a fat here. That will be done on 2D echocardiography. And spot diagnosis on heart is by fluoroscopy, where I as a registrar, I must have done thousands fluoroscopies. In every OPD, 100 to 200 every OPD. In the OPD, when you see the hilum and when you see the hilar vessels dancing like this, we call it hilar dance. That is, that patient has got congenital heart, ASD or PSD. If you see calcium like that, this is constrictive pericarditis. This is pulmonary hypertension. Very bad disease, very bad disease. The pulmonary artery, see the aorta is there, below that aorta pulmonary artery. And below pulmonary artery there is a concavity. If you notice this concavity. Why? Because this is the left atrium. The commonest cause of pulmonary hypertension is mitral stenosis olden days. Then this will become straight. This is not straight. So this is, now this could be either due to ASD, VSD, congenital heart or primary pulmonary hypertension. Primary pulmonary hypertension is very rare and bad. You are going to die. You are going to Madhuwala and all our actresses and all, they all died. Of course she had ASD. So this patient also was a lady doctor, came to me and they said primary pulmonary hypertension. It was diagnosed 10 years back and 3 doctors, specialists had seen her. The trouble about cardiologists is this, that they all see 2D echo reports. They don't do echography themselves. You see in America now, all cardiologists must have echocardiography machine. All gynecologists must have sonography machine to see the uterus. They are not going to feel the, this is gone. So now this time has come when all cardiologists must keep 2D echo and do themselves. When they do themselves, then this will not happen. That they went on saying that this is primary pulmonary hypertension, means there is no ASD, no VSD. When I saw this X-ray only, and she has become a doctor, already lived more than 10 years. You see these blobs there, this blob, see this blob, and I have seen this in dozens and dozens on fluoroscopy. I did fluoroscopy for 40 years, then the government has banned it. It's bad for the patient, he might, radiation. What about you? When you get radiation, the child specialist merchant and all burns of the hands when he used to do fluoroscopy. Fortunately, I escaped all the complications. But beautiful investigation which is not being done, because machines are not being made. And if you get a very big shadow like that, yes, this is spot diagnosis. See, it's such a huge shadow and the lungs are clean, absolutely clean. Moment it is that diagnosis is pericardial effusion. This patient will die if you don't take out the fluid. He will have 2 to 3 liters fluid inside. And their symptoms are mild, they don't move around, and fever, definitely weakness. And so X-ray can diagnose. And if some of you want to become clever GPs, if you can learn this straight line, mitral stenosis is the only rheumatic heart disease left in India. That is also going away. If a lady comes with bronchitis, diagnosis, asthma and hemoptysis, bringing out so much blood and no tuberculosis, think of mitral stenosis. Mitral stenosis, heart is not enlarged. But what happens is, this line becomes straight. See this straight line? Why does it become straight? Because if you below the clavicle, leave a little bit, this is aorta. Then below the aorta comes pulmonary artery. Now this pulmonary artery has also become big because it is competing with aorta. Now below that, that concavity which I showed you last time is the left atrium. When the left atrium enlarges, then this becomes a straight line. And once it is a straight line, in mitral stenosis, 100%. And radiologists always miss it. Some GPs can diagnose, and you can see that the breasts and all that, because it's common in females, young females, again young female. And when they develop symptoms, mitral stenosis, then you get shadows in the lungs. Then they need some treatment changes. And any heart patient with an enlarged heart, if there is a shadow, any shadow, that shadow, fluid shadow, it's pulmonary infarction. Pulmonary infarction, simple. Do blood D-dimer and you'll be right. You'll be right. So pulmonary vessels we don't study because finally the bones, some people diagnose, radiologists, multiple myeloma, secondary deposits in the lung, osteomalacia. I don't trust. I'll diagnose multiple myeloma in a patient, elderly patient who is anemic. How can a male patient become anemic whose urine shows albumin? And then blood proteins are very high. I'll diagnose secondary deposits in a patient, common as PSA. PSA is not done. And this patient, as I told you, that golfer who died, my whole body was full of secondary deposits. Osteomalacia, I'll diagnose by body ache, weakness, and then I find alkaline phosphatase is high, vitamin D is low, and PTH is high. PTH is high, that is osteomalacia. Thank you.